Heidi Ho neighbors, how are you doing tonight? Welcome to another Thursday night's edition of Invisible No More right here on the Eclipse Pain Network. I'm your host tonight, Keith Johnson, obviously. Thank you for taking the time tonight to join us. We have as guests in the studio will be Dr. Leek. We were supposed to have Queen Amy here tonight, but there was a family issue that came up. She is fine. She says that she is okay, but she can't make it tonight. So I apologize for that. She apologizes for that. And she'll be back ASAP. It's just kind of a one-time thing. You know, it's something about being invisibles. Sometimes our schedules get rearranged whether we want them to or not. So I'm going to miss her tonight, but we are here. If you're new to Invisible, what is Invisible? Invisible No More is simply this. It's a group of people, a group of I call us ragtag misfits, that are combined with people with a diagnosis of chronic illness, chronic pain, and or mental health struggles. And technically, you don't even need a diagnosis because, as I've said before, we've proven it's taken 5 years or longer for some people to finally get a diagnosis. Are you fighting the symptoms of a chronic illness? Are you fighting the symptoms of a severe mental health struggle, bipolar depression or something like that, or even more? Are you living with chronic pain on a daily basis to where your quality of life is in the crapper, even though there's no known reason for it yet? Well, this is your family. This is the safest place on the internet. Invisible No More, you will find nothing but love and support, regardless of the path you choose to try to get better, because that's all we're trying to do, is try to find ways, working together, sharing our experiences to try to be a little bit better every single day. Good experiences, bad experiences, ugly ones, not just procedure-wise, but relationship-wise, world-wise, you know, society-wise, and our total environment-wise, because it's all about quality of life, whatever battles we're fighting, is we just want to try to have a little bit better quality of life. And unfortunately, what some of our diagnosis is, or some of the conditions we're dealing with, there probably isn't a cure. We're not going to wake up tomorrow and be normal in somebody else's eyes. But how can we wake up tomorrow and try to be a little bit better? That's what we do here. We don't med shame. We don't treatment shame. We support you. So that, in a nutshell, is Invisible. And what are we doing tonight? Wow. It's going to seem weird. But before I get into that, I'll introduce Dr. Leek. I'm sorry. Dr. Leek is here in the studio. And Dr. Leek, if you would one more time explain to us what makes you a member of this Invisible community. Because you are. We covered it last time you were here.
Sure. Hey, y'all. Dr. Dustin here. Nice to see y'all. Keith, thank you for hosting me on your show once again.
Again.
We always have a good time together.
We try to.
So for those of you who don't know me, I am a double board certified pain management physician, and we have our own practice here, Eclipse Pain and Recovery, in business now for approximately 5 years. And we wanted to get into this space online because we realized there was a great need to provide educational support, and maybe some clarification on certain narratives as it relates to pain management. It's obviously a very controversial field, and we just want you guys to have the best information possible to make the best decision for you and you alone. That's what we're here.
And that's what we've done, whether it's been some of the podcasts that you and I have sat down and talked about specific topics, or it's these lives, or it's your show on Monday nights, right? Or even that I want to include Katie's show on Wednesdays and Jose's show, you know, as a strength coach on Tuesdays, about working together to find ways to be a little bit better, to have a little bit better quality of life. I love Katie. I've never knew that changing my diet could impact me like it has. Jose, when he stuck me with needles, actually really helped a lot. I need to get back and try to figure out how I can get it done again. And we talk about different procedures, and I've been doing this thing called Keith Tries, which that's with Jose with the needles, right? To try to demystify some things. So with Jose, it was dry needling is what he did. And with Katie, I gave Katie my diet for 4.5 days. Essentially burritos 3 times a day. Diet Coke, you know, got to have the Diet Coke. Can't have a real Coke.
Got to be diet. Yeah.
Got to count the calories, right? Have those burritos. And we've done it one more time now. And what I'm talking about is recently, we had, make sure I get this correctly titled, Epidural steroid injections. Is that how you want it? Or is it steroid epidural injections?
Yeah, epidural steroid injections, or ESIs is how we refer to it.
Okay. Which is essentially this really long needle, like 10-foot long needle that they stick in your back.
Not quite that long.
It might as well be for me. And
Keith has trypanophobia, fear of needles.
This is true.
I do have smelling salts though, if we need it.
We may need it. That'll be the best clip we can ever have. Me passing out when I watch this. So basically, they take the needle, they put steroids and other stuff in it, and you put it in your back, right? Where did this come from? Who sat around one day and said, "Hey, maybe this is a good idea"?
Well, it's actually sort of a fascinating history. The epidural, accessing the epidural space has been around since probably the early 1900s.
Really?
Yeah.
They were doing that way back then?
They were. About 80 years before X-ray guidance. Yeah.
Holy crap.
So, but they weren't using it for pain so much. I mean, they were using it for anesthesia was the purpose, not for chronic pain, but more for like surgeries and things of that nature. And it wasn't until World War II. So there was this myth about the German pilots and the super pilots. Now, this has never been confirmed to my knowledge, but that, because they're flying pretty much around the clock, how are they able to do all this stuff? The myth was that they were extracting some adrenal hormones, i.e. steroids, and then giving them to the pilots to stay awake and do their job. And so that sort of led to some research, and I don't know exactly how we came up with it, but there were some researchers out of Mayo Clinic that showed, this was just after the war ended, that steroids were effective for rheumatoid arthritis. In fact, they won the Nobel Prize
really?
At the time. I think it was 1950 or thereabouts.
Wow.
So then we started using it for these, multiple inflammatory conditions. And someone had the bright idea, well, we've already been doing epidural interventions for anesthesia. Why don't we inject steroids into the epidural space? And so they've been doing that since about 1952, which I remember because that's my dad's birthday. So
It's crazy that it goes back that far.
Oh, yeah. And, and they were doing it by anatomic guidance for 30 years.
That's
So
even crazier. There
was no fluoroscopic guidance or X-ray guidance up until about the 80s when that became popular. And even now, I mean, we do epidural procedures for labor, just like we were in the early 1900s, and we don't use any guidance for that too. So,
see, that's my next question is because when I came into the pain family and when I got hurt, and doctors were talking about, we'll get you an epidural and see if that helps. And I'm thinking, I'm not having a baby. I'm not. Why am I getting the same thing? And so I went and had it done, and I'm like, I can walk out after this? Why is this an epidural? But my wife at the time had an epidural with the kids, and that was totally different.
Right. Well, I mean, the word epidural implies that we're accessing the same space in both settings. So we are accessing the epidural space, which is the space above the dura, which is the sac that surrounds the spinal cord. So to put that in perspective. So the epidural space. So when you're getting an epidural for delivery, let's say, often they will insert a catheter and route it up to the appropriate spinal level and then flood in some medication to help block that pain, waist down, basically. Right. So the purpose there is to block the pain, and that's pretty much effective as long as the medication's running through that catheter. With an epidural steroid injection, that's the difference. Number one, we're using a steroid, whereas with the delivery, we're not. Mm-hmm. And then, of course, it's just an injection. We're not inserting a catheter or leaving a catheter for any prolonged period of time.
Thank God.
And so the goal is not a pain block in that case. Otherwise, you wouldn't be able to walk home like you did.
Right.
All we're doing there is modulating the pain, reducing inflammation, swelling, pressure around those nerve endings, and helping your pain.
So, am I right in saying like the idea behind it is you put steroids around a disc or around something that's inflamed that may be pressing up against a nerve, which is causing pain, like I'll just be honest. My case, it's a radiculopathy,
right? Which
is like this pain that comes underneath my man boobs, and especially on the left side, feels like I'm having a heart attack. Like if I'm laying flat on the bed, I can only take a half breath. Or if I'm behind the wheel of a car, something about that position triggers it as well. And so I guess so. In theory, the steroids will hit whatever's hopefully swollen and hopefully shrinking enough, possibly to take some pressure off.
Right. Okay. Exactly. Yeah.
Okay. Now, this is not a permanent fix if it works.
No.
Right?
No. In fact, the studies are pretty wide ranging, and it does allow for certain advocates or those who want it to see it disappear to make their own individual arguments. So it is somewhat of a controversial topic with regard to whether we should keep it around or not. But what I see in practice, which I would say is what I've been taught, and also kind of takes all the studies from a very high level, about 50% of people will experience about 50% relief of their pain for about 50% of the year. And it's a bell curve. So it may not work at all or very short, maybe a day or maybe a week or two. And then we have a handful of patients that get a year or more out of it. And I know several of those as well that they're starting to filter back in, a year later. So it really just depends. I would argue that probably the longer you've had pain, the less likely it is to work long term, okay, the injection. And a lot of that has to do with the centralization of your pain, the patterns that are made in your brain and your spinal cord. Even if we take away the insult, the brain remembers, and so you still have pain. Right. But the sooner you have, or the shorter you have pain, the more acute it is, the more likely it is we're able to pull you out of that longer term. So
could this be used for acute?
Oh, absolutely. It is, yeah.
See, I wonder why they never tried that when I first got hurt.
So it just depends on a lot of different factors. Usually when we use it real acute to the injury, you're probably going to be in so much pain, like you're in the hospital, they're giving you IV meds, and you really can't do much. Surgeons seeing you is really nothing to cut. It's just pain. Right. In that case, yeah, we'll pull out the stops, do an injection. But for the majority of people with acute spine injury, about 50% will get better spontaneously within 2 weeks.
Really?
About 80% in 6 weeks. So in practice, we don't typically rush to an epidural injection until at least a couple months has passed and we've tried and failed more conservative treatment.
Okay. I would just blame it because my injury was a workers' comp injury, so they're not going to spend money to do anything besides gabapentin.
Workers' comp is a whole different ballgame. Yeah, I don't do workers' comp.
Yeah, especially here in the state of Texas. Oh, my gosh.
Yeah.
Could write a book on that one. So just some more background on it. They're typically not a permanent solution, and you don't probably want to get a whole lot of them done unless you absolutely have to.
Right.
We've talked before in previous broadcasts where maybe one a quarter, so 4 or 5, maybe a year,
right,
would be kind of at most, right?
I think, yeah, some of the official recommendations will allow up to 6, but you should have a good reason to do it.
Yeah, and I think Amy talked last week about how sometimes there's miscommunication between care teams and patients, where we take a treatment as going to be a fix, or something we can continuously do until from here to eternity. Right. When the doctors or the care teams know that's not, but that for somehow or another there's miscommunication there, and I'm not blaming. Yeah. I'm not going to blame anybody.
Yeah.
In this. Well, I can blame some, but I won't. Because I'm just going to say it's miscommunication.
Yeah. Yeah. So, I think we are also trained because we understand how much the expectation of a patient will dictate the outcome. Mm-hmm. And, that can be sort of controversial because it's like, well, if it works, it's going to work, whether I believe it's going to work or not. But actually, that's not really true. There's a huge placebo effect and nocebo effect with almost everything we do, especially pain management. I mean, there's studies to put it in perspective where we would give somebody, we would simulate an injury. So we'd cause their arm to experience heat to the point of pain. And then we would give them an IV medication. We tell them it's fentanyl and it's actually just saline. And
I would punch you so hard.
Right. Well, I mean, they know what they're getting up. So they think they're getting fentanyl. Right. Pain goes away. Yeah. Right. And then the converse of that, converse.
You guys chucks on you.
There we go. The converse of that is we would give them fentanyl, telling them it's saline, and they still have pain despite getting the fentanyl. So it's all about your expectation.
It is, and
not all, but it's a lot.
It plays into it, right?
It plays into it.
I could see that if I went into this procedure hoping it works, optimistic it's going to work, but not to the point that I'm going to have my soul crushed if nothing happens.
Sure.
Does that make sense?
Well, and I think that's where some of the miscommunication comes in, because a lot of times, and myself included, I will upsell the procedure in the way that, like, hey, this is really going to help you out. And I want you to go in feeling optimistic, like that's important. I mean, there are situations where I'm like, no, this is not going to, and we may decide or not decide to do it depending on the indication. But even still, I don't want to gaslight a patient, because I think we should be honest with our statistics. But I would say that, it's like, well, given everything, and even though there's only like a 5% chance this is going to work for a year or longer, I know this is going to be you.
Okay. See, and that conversation goes into what I've been calling the cost benefit analysis,
right,
of this procedure for me. And for me, y'all, it's not just this procedure. It's on each medication that I take. Right. Is it worth the actual cost, right? Number one, how much is coming out of my checking account? And then is it worth the cons? What's the side effect of this medication? What's the side effect of gabapentin? Or what's the side effect of an opioid? Or what's the side effect of the steroid injection? What can go wrong by me either taking this med or getting this procedure done? And then I weigh that with where my personal pain level is, because, like I keep saying, we all have different fingerprints. So our pain and our tolerance is all over the place, right? Mm-hmm. So for me, it got to where I'm tired of dealing with this. Mm-hmm. And what I'm doing now isn't changing anything. At most, it's sometimes masking it, right? And then for me, I get into how much relief do I need out of this? Am I expecting 100%? No, probably not. 50%, I would love 50%. But for me, if I get 20% relief out of this, it was worth every chance I took and every dollar I spent. Because my goal is to take less opioids. My goal is to take less pain meds. That's just me. Again, everybody's different. And I tell everybody, you be you. Live your life that you need to live for your best quality of life. But for me, I have this mental thing in my head. I want to get down on my opioids. So if I can get 10 to 20% relief out of this, hopefully I can go back. I can step down on my meds. Yeah. And it's worth it. And it's going to be different, right? But we need to do the research. I'm going to just be brief in this because I'm tired of bringing it up. Don't buy the hype when somebody tells you that the worst case scenario happens to everybody. Right. Okay? Don't. Do your research. I have horrendous stories just from my recent social media post about me doing this. I was paralyzed, or I was temporarily paralyzed. And it's like, I'm sorry that it's happened to you. I really am. I hate it when things go sideways, and especially when a patient's trying to do what they can do to be in a better spot, and then it gets jacked up. What a nightmare, right? But at the same time, I can't let influencers tell people that 9 million people a year are getting paralyzed, because they're not.
Well, that's how many injections are done. Yeah. So not everybody's getting.
No, but that's what they're preaching. So I want people to understand.
That's a lot of lawsuits.
Yeah, I don't think they'd be doing them anymore.
No.
I mean, I want people to understand it's may, could possibly, can, not, will. Does that make sense? Because that's not what's being preached in a lot of circles out there. So my cost benefit analysis was like this. When this is spiking, I can't, it hurts just to breathe. Mm-hmm. It feels like a heart attack. That's the sharp pain that's over here. It's not consistent. It's not 24 hours a day, 7 days a week.
And for those of you wondering, it's not as hard.
No, it's not.
We checked that out.
Yeah, it's not. So I'm tired of dealing with it. Mm-hmm. The pain level when it happens is intense, and it's truly impacting my quality of life. To get this done, there is at most a 1% chance it can go sideways, and I would walk in, and then I would not walk out of the room, right? The other side
1% is really high to not walk out of the room, for the record.
I'm being generous.
Yes.
Then the other downside is it may not work, right? It cost me, did the math sitting here before we got started, because when you have this procedure done, you can't drive for 24 hours, right? So I had to drive up the night before because I was in a town different from where I live, get a hotel on Sunday, get a hotel on Monday because I can't drive. Between that and my deductible for insurance, it was $698 to have this procedure done. That's actual cost out of the checking account that I'm hoping to get 20% relief from. Because to me, that's how bad my pain is. So your pain may not be that bad. And at $700, it may be like, no, there's no way I'm going to spend $700 to get 10 to 20%. Right? And I would never tell you to do anything that you had to go do anything anyway. But that's why we all need to sit down, piece of paper or on a spreadsheet, and list out what's the cost, what's the cost and the possible side effects, what's the possible benefits, and then take those and put it into your current pain, and figure it out for yourself. Not follow me, not follow anybody, because it's all about personal care and where you're at.
Individualized care.
And talk with your doctor, talk with your care team.
Right.
You know, if you're really worried about the serious side effects, talk to them and see if there's a way that can be stepped down or better understood, or maybe there is a misconception that it is permanent, or you can do them once a month for the rest of your life. Right. Because an educated patient, even though I know there are doctors out there that hate them, to me, an educated patient is the best patient.
Absolutely.
We need to know the good, the bad, the ugly. When people share their ugly experiences, take it to heart because it really happened. But when people share their good experiences, take that to heart because that really happened as well.
Yeah.
Show care, compassion, and empathy for people that it did go sideways for, but celebrate the fact for people that it did help, I guess is my preaching point on that one. So that's why I did it. Because this hurts. When it flares, man, it will wake you up from the deepest sleep. My dog has looked at me in the bed going, what was that noise you just made? Because it's been that intense.
Right.
And then we'll get into what happens next, but I think we have some video, Kevin.
I know you all been expecting to watch this.
I've been teasing this the whole time.
Right.
This Keith Tries, they filmed me when Katie interviewed me with my burrito fascination. You guys filmed me when Jose gently stabbed me with multiple needles. So we figured, what the hell? I'm having the procedure done. Let's do some Keith Tries steroids. And that's what we did. Oh my God, look at that pale skin. I need to get out in the sun. I love how you strap me in like that.
We don't want you kicking and falling off the bed. The bed is real narrow.
I heard a story about that we'll talk about afterwards. So
here we're doing a timeout. So she's calling out your name, date of birth, the procedure we're doing, and making sure there's no allergies. And then we all agree. So we want to be safe before we do the procedure. Make sure it's the right patient, right procedure. And here we're just cleaning your back, putting some soap on there, wiping from the inside out. Proper technique for all those watching.
I told people to watch you when you were doing that.
Yeah. Those are cool tats, by the way.
Those are bad high school
ideas.
Man.
There you go.
That one, at least. So.
Yep. So we're putting on some sterile towels, just sort of to mark out the sterile field, make sure we kind of play within the fence.
And I'm getting ready for Dr. Leek to run across the room with the smelling salts, by the way, because I think I'm fixing to.
Now, Keith, can I talk about? I'm talking about it. I guess I have your permission.
Yeah.
He's doing this procedure without any anesthesia, also. So we can do it with anesthesia. A lot of patients might prefer that. Actually, the official recommendations argue against it just because of the risk-benefit ratio, but it's still commonly done given the relative low risk anyway.
Right.
But you went without, and I mean, what was your experience? Was it real painful to go without?
No, it wasn't. I've had them in the past though where they were. This one was smooth.
He knows all the right words to say. He's on the right show.
No, I felt the initial injection.
Yeah.
Right.
Where we're numbing the skin.
Yeah, the lidocaine one.
Okay.
I guess, whatever it was. And then when the whole process, there was pressure points, and that hurt like a son of a bitch. But that was like 30 seconds.
Right.
And then dissipated. And that was it. I was extremely happy that I didn't get anesthesia, because even though the new anesthesias, they can wake you up really quick and you're not groggy and everything, it just saved me extra amount of money, because for me, I didn't need it. But again, if you want to get knocked out to do it, do it. Just get knocked out. Like if and when I end up with nerve ablations, you were definitely knocking me out, because I don't want to be awake at all for something like that. But yeah, I was surprised. I was paranoid. Well, you saw my blood pressure going into it. I was paranoid about how bad it was going to hurt without the anesthesia. And I was, it wasn't nearly anything like my worst thoughts.
There you go. Awesome. So let's keep watching. I think I'm just checking on you there, making sure you can still breathe. All the towels on top of you. That's our big x-ray machine. So we're taking some pictures, and I can see it there on the screen. That's his spine. You can see over my shoulder. And right now we're kind of taking our time counting the levels. So in Keith's particular case, we were injecting between the thoracic 4 or T4 and T5 levels. And that needle there is kind of serving as my marker.
That was laying on my back. Right?
Yep, that's just laying on top of your skin.
Okay.
And I just put it there so I know what level we're at, and we're just moving the camera up and finding the T4 level. Incidentally, I mean, we know that there's a disc herniation at that level, which corresponds with the location of your symptoms.
Right.
And so now you can't see that, though, on the x-ray, for those of you wondering. We can just see sort of a brief outline of the bones themselves. The x-ray dose is really quite low. Even if we were to get a diagnostic x-ray for you, like a chest x-ray or something like that, it would be more radiation than what we're doing here. This is a very low dose.
Very low dose.
Mm-hmm.
Okay.
Yeah. That's the needle there. So again, we're just sort of marking the levels. This is not as difficult if we were to go in the cervical spine or the lumbar spine. It's pretty obvious where we are. But in the thoracic spine, you really can't fit the whole thing on one picture, and every level looks pretty much exactly the same. So it takes a little more technique. And she's got her lead on, our fluoroscopy technician, and I got my lead on in case you're wondering what we're wearing.
Everybody but the patient.
Yeah, well, we stand in front of it a little more than you do.
And me.
So I'm guessing this is the lidocaine?
This is the lidocaine, so I'm kind of brushing your skin there to make it a little less sharp. You can see the bump in the skin. That's our wheel, a lidocaine wheel. And in goes our TUI needle, 20 gauge TUI needle. It's about 3.5 inches. Are you okay, Keith?
I'm fine. I'm fine. I did not need to see that last one.
All right. I can jump up whenever you...
No, I'm good. I'm good. Just
right.
Don't
fall over.
No, I'll be fine.
I want an insurance claim. All right. So right now we're still pretty posterior, just inside the skin. But that's where we want to be there on that level. Just advancing a little bit further. I'm actually going to land right on the bone.
And you talked about that.
Yep.
You're like, see, I'm on the bone.
Yeah.
Yeah. I remember
bone. That tells me I'm in a safe spot. Here, hold on just a second, Kevin. So once we're on the bone, we kind of walk it north and just fall off the ledge. That tells me I'm in between the space between the two bones.
Okay.
And obviously we don't want to advance it too far at that point.
Right.
But that tells me where we're at. And then this next part that we're going to be looking at is the loss of resistance technique. So the epidural space is a potential negative pressure space. So once that needle breaks into it, the air in this syringe will collapse down because of that negative pressure. And that helps me know I'm in the right spot. That's the same technique they were using actually back in the 1900s before fluoroscopy. Really? Yeah, it's still stuck around. So once I found that, here's the contrast. We're just injecting a little bit of contrast. And you can see there, nice, beautiful spread. We're going to confirm this on a lateral view. I don't know if Kevin got that or not. Yeah, okay.
It's just weird seeing my spine like that.
Now we take a picture from the, okay, yeah. So Kevin didn't, go ahead and pause it. He didn't get the picture here, but we wanted to see the needle on a lateral view to make sure, like a double safety check. Actually, this would be a third safety check when you take it all into account, that the needle is posterior to the spinal cord.
Explain that in English. What do you mean?
So, let's say here's your spine. Needle goes down right here. I want to make sure that the needle kind of stops here, like right here, and not, so far forward.
Okay. All right.
But I have to use it on the lateral view to see that. So.
Okay. Thank you for...
We call it like a safety view.
Okay.
Once we confirm that, which we did, although it didn't get on the video, that's okay. Now we inject the steroid. And it went in nice and smooth. Sometimes if there's a lot of pressure, it probably tells me I'm not in the right spot, but that's just another way to know that we're flowing. A little bit of lidocaine, and out comes the needle.
This took like 7 minutes, 8 minutes. At least that's what it seemed like to me. I mean, it could
If
have,
that, yeah.
when I was on the table, if that long. I was shocked how quick in and out it was. I waited for Kevin to get to the car to take me back to the hotel longer than it took you to do the whole procedure. So, and
it's never the procedure. It's always the before and after.
The before and after,
yeah.
Which I will recommend. Hillsborough, that hospital, fantastic in that OR. That room.
Awesome.
They were just freaking rock stars. They took really good care of me. Really nice. We talked about fishing and hunting and all sorts of stuff.
It's a good group of people down there.
Yeah, they were fantastic. So that's it. See, I even got the thumbs up. I'm alive. Look at that look on my face. Like am I dead? Am I dead? I don't know.
There we go.
So it took about 7 minutes, and they're unbelting me here. And like I said, I have a good story to tell you off the air about that one. But they flop me over like a fish, right? And that's the benefit of not being under anesthesia. I could just roll over myself. But don't be afraid. If you want anesthesia, do it. By all means, do it. My fear in not using anesthesia for a procedure like this is not being belted down and my body reacting to something, not necessarily you or another doctor screwing something up. I'm so paranoid that my body is going to jump, that it's going to move a needle somewhere and the needle's going to go somewhere else.
Oh, yeah. If I have a patient that I know is a little bit anxious, I mean, you were a little bit anxious, but you've also done this before. Yeah. And you reassured me that you were not going to move.
Do everything I could not to.
And you did not move. But I do have some patients where I get a little like, I don't know if I can trust you. And I will recommend we do a little bit of sedation.
Yeah. Or maybe just a Xanax or something beforehand, But that's my fear. My fear isn't necessarily on you or another doctor doing it. It's on me, my body just reacting, and then I'm screwed. Just the reaction. But I wanted to show people this, not to be like for clickbait or anything, but to show what it's like. Because when we have them done, you're laying on the table, you don't see anything going on, right? You don't see the needles, you don't see anything, which is great for me. But I wanted to kind of demystify. It's not like everybody. Like you have a team of 100 people in there watching over you, and it's not like they're not doing, like you said, you're triple safety guards trying to find that spot, right? Where in my head, I've never knew that there were, I would hope that there were safety measures going on, right? But I never thought that there were like 3 different things,
Oh, 3 different things just for me. I mean, all the staff around us has their own protocols as well.
Oh, yeah.
Yeah.
And to show that there are procedures built in to help keep that risk as low as it can be.
Right.
And we're hoping it's going to work, right? We were hoping that there will be some relief out of it. And I wanted to kind of demystify it, just like the embarrassment of sharing how horrible I eat with Katie, and then with the world, with Jose stabbing me not falling out of that chair when he stabbed me. I wanted people to see that as this is a serious procedure, outpatient, right, in a hospital in case something goes wrong, that it wasn't as bad as it built up in my head. But everybody's different. I'm not telling everybody to call your pain doctor tomorrow and schedule an Epidural and ESI. Please don't do that. But if they bring it up to you and you haven't had one in a long time, I haven't had one in probably, I have to look at my records, 4 years.
Yeah, it's been several years. Yeah.
You know, maybe try it. I've noticed my body is reacting to different things differently now. Like initially, the very first time I was hurt, gabapentin didn't do anything for me. Now I am getting a little bit of benefit out of it. So that's why I figured we would go ahead and we would try this, right? I do not want anybody to walk away thinking I'm minimizing the people that were injured when it went wrong.
No, not at all.
Because I would never do that. That's not part of my soul and not part of my spirit. But at the same time, I want people to see that it can be done in a safe, managed way with proper protocols. And then you let the medicine, you let the steroid do the rest. And then we determine.
Yeah.
Right?
Yeah.
So afterwards, it was no driving for 24 hours.
Right.
Right. I didn't have sedation, so I still went back and I slept like a rock for I think it was just the feeling of being done with it, you know. But from that point on, I've been in 2 different states. I've driven 600-700 miles, right? It hasn't anything that's prevented me from doing normal day-to-day life, right? But on the same point, it hasn't really kicked in yet. So we're looking at 2 weeks, maybe upwards of 2 weeks before it could make a big difference.
Yeah, it takes about 2 weeks. I have some patients where they get really great result pretty much right out of the gate. I'm not sure exactly how to explain that. Based on how we understand the medicine to work, it can take up to 2 weeks. Some patients, literally no relief until day 14.
Really?
And they're like, oh, I feel so much better now. Like, okay.
Wow.
Yeah. So.
Huh. I can't tell anything right now, but we were talking, Doctor and I were talking before we got started. One of the things that triggers me is being behind the wheel of a car. And seriously, I spent a lot of time behind the wheel of a car. And so I know I was aggravating it the entire time. So if it did start shrinking it shrunk it from really bad to just normal bad, right? That's how my pea brain makes it work. I know I have to break it down in little baby steps sometimes.
Yeah.
But so we'll see, you know.
Yeah.
But that goes back to your cost benefit analysis, right? Is it worth it to you? Again, if I get 20% relief out of this, it's worth every penny of the $700. Because mentally, that tells me I can probably go down on my meds. And if I can go down on my meds, that is a big weight just off.
It feels like a win.
Yeah.
Well, that's part of your goals of care.
Yeah.
That may not be somebody else's goals, but that's part of your goals of care. Yeah.
You know, and that's a very good point. This is all my plan. This is not your plan. This is my plan. And if it works, cool. I realize that if it works, it's not like every 3 or 4 months, I'm not going to come back. Right?
I already got 6 more lined up for you, Keith.
Yeah.
I'm just kidding.
Was it Jamie that had 17? I forget who it was.
There's a few horror stories out there. Yeah.
Somebody had 17 and you made the comment, what's the doctor thinking? Well, 16 wasn't it, but 17's the right one.
That's the magic one right there. Yep.
And we hear horror stories, and it's been honest to goodness happened where bad doctors have forced this procedure on patients, and in order for them to get other type of medication or other treatments. This should never be a forced thing. No doctor should force any type of treatment, in my opinion. I understand the fear of having and the hard work it takes to try to find another care team, but at the same time, blackmailing. That's why I left my previous, because it was all, well, time for a nerve stimulator. I'm like, no, we haven't tried all of this yet, So if it works for me, great. I'll probably, depending on how much relief I get, will depend on if and when there's another one, right? If it doesn't work, I think we'll have a conversation about moving on to like nerve blocks in that area, because insurance will require it leading up to a possible nerve ablations is kind of what I'm thinking in that area.
Yeah.
nerve ablations for me have worked really well in the past. So I'm hoping the steroids work, and then I can be done for a while.
Right.
Instead of having to go through the process of the nerve ablations. But if we do, we can film that too. I don't give a shit. I know nerve ablations to a lot of people are a lot like injections, steroid injections. It's either a yes or a no.
Yeah.
Because they've worked really well or they haven't worked. I'm blessed because they worked really, really well on me. They must have burned it was the doctor in Las Vegas that did it. He was young. He was a baby doc from Brooklyn. How he ended up in Vegas, I have no idea. He must have burned the bejeebies out of those things and scared him to death because they grow back, right? They were like not even thinking about it for a long time because he scared the crap out of them. I mean, I got like a year and a half.
That's good.
Right?
Yeah.
Where sometimes it can be 6 to 8 months,
right?
Right? Before they grow back. And I know nerve ablations aren't a permanent fix either because each time you do it, when they grow back, those nerves are smart. And then they start growing back in different ways and make it more difficult to try to get it done. So it's not a cure. But can it help a little bit better quality of life? That's what we're after.
Right.
Right. So for me, it's steroids, hopefully lessening the amount of opioids I have to take. If steroids don't work, then we'll have conversations about nerve blocks, which would lead to nerve ablations. If those don't work, then you're like, Keith, you're stuck with opioids for the rest of your life because your next one was going to be a nerve stimulator. And then, no, we have more options still.
Oh, yeah. There's always something.
We have more options. Kevin, we have any questions so far? Have people been yelling at me in here?
They're proud of you. They're proud of you. I did see one question, though. Let me scroll back up here real quick.
M-Buck says, any thoughts on why ESI would only affect one side of the back? Yeah, that's a good question. So you actually have a piece of connective tissue. It's kind of like saran wrap, so to speak. And we call it the dorsal raphe, R-A-P-H-E. And it separates the left from the right side throughout most of the spine in most people. Now, there are some anatomic variations, but when you're going in, let's say, in the middle of the spine to do an injection, it's possible you're just on one side or the other of that connective tissue, and so the medicine will be directed to one side or the other. It doesn't always happen that way. Even if you do have it, there's still some holes in most cases. You can get bilateral spread, but that's usually the reason for that.
So did you get both sides of mine?
I hope so. It was a little bit, you saw the picture with the contrast, it was a little bit more left-sided.
That's okay, because it's typically more left-sided than it is right-sided. So,
right.
So I'm fine with that.
Yeah.
But I was just curious. You know, that's a good question because I didn't even think about that because when treatments have worked, I've never questioned why it was. I would just say, heck yeah, man.
Oh, sure.
Something's worked, you know.
I mean, that's one reason. Another reason could just be that there's more of a pinched nerve on one side than the other. So the medication just didn't work as well on one side.
And that makes sense too, you know, because we're all, that goes back to one of the things I wish we could really, especially for newbie to the invisible to the chronic pain community, is just start getting to people's heads that not every medicine's going to help you. It may work great for me or great for Doc or great for Kevin or great for Buck or great for Kimberly, right? But it may not work for you. Toradol is a good example. I can think of a bunch of them that may or may not have an impact, right? But the thing is, trying to find that relationship with your doctor so you can try whatever you can try to find what does work for you and run with it. I mean, I've said it 100 times. I'm a big proponent of the Velcro method, right? Throw everything we've got at it and keep what sticks. So just my thoughts on that. Seeing if there's anything else.
You got a lot of support, man. Everyone's proud of you.
A whole lot.
Well, they know my feeling on needles. I can't believe I made it through that. Barton said nerve ablation. I'm getting desperate, so I need to look into that. It's I was scared crapless. I told doctors that there was no way in hell I would ever get it done.
Yeah.
And then, like where I'm at now with this, my pain's to the point that at that point I was like, burn whatever you have to burn.
Do you want to see the needle?
No. You can show the camera. Go ahead, show the camera.
Keith is looking away right now. Yeah, so I don't know if you can see. Yeah, there you go. There we go. Something like that. So it's this particular needle is what is not exactly what we used on Keith, but it's about the same size. And I'm going to put the cap back on so you can see it. It's just a piece of plastic, Keith. There's no needle here.
No, I looked at it on the YouTube screen and I saw it.
Don't do that.
I know.
You'd be surprised though. This is a pretty standard needle. So here's the spine. Some patients we have to get even a 5-inch or a 7-inch needle. You want to see that, Keith? No, he doesn't. I just want to break open the smelling salts.
You're close. You're getting close.
But no, it's you don't really feel it. The worst part is the skin.
Move that.
You want to put it away?
Yeah.
Okay. Sorry.
Yeah, please. Thank you. He leaves it sitting out on the table right in plain
Just
view.
Display it for the camera.
Knowing that I don't want to look at it.
We kid.
Oh my God. I'm going to need Xanax by the time I get home after seeing that. Jiminy Christmas.
It's definitely better being on this side of it. I'll tell you that.
On the sticky side than the stick side?
On the stick side, yeah.
It's not on the stabber side versus the stabby.
Well, they've talked about physicians that do surgery. Think about that. Like you cut somebody open, move their guts around, like readjust broken bones, or manipulate spinal structures with needles and stuff. It's like to be okay with that, you have to be a little bit different. I'm just going to leave it at that.
Thank God there are people like that. Yep. I'm just going to say
well, if you wonder why you can't connect with your doctor, well,
yeah,
they're
different.
A little different
right there. I mean, like at our house, just to give you kind of a gross example, if the dog throws up and I'm the one that finds it, I'll throw up as well.
Wow.
I can't do it.
You're like a super empath.
Yeah, I can't. It just grosses me out. I'll make a bigger mess than the dog did. Right. So, future reference in case we're visiting and your dog throws up, don't let me see it because it'll be a bigger mess.
Yeah.
So yeah, I'm glad there are people out there that can do that. And not only can they do it, they want to do it. Right. Because yeah, that's not my skill set.
Just got to look at the world a little differently.
That's not my skill set. Bug says they're one of the weirdos that just prefers to watch. Yeah. I don't know. I think it went good. I know the procedure went well. Staff was great. You were great. I built so much of it up in my head because I've had previous ones where they did hurt. That's what I was expecting, and it was nowhere near that. There was just a really brief pinch when that very first lidocaine shot, and then pressure when you put the dye in, and then pressure when you put the steroid in. Mm-hmm. Both of those lasted about 30 seconds, and I was underneath my breath, right, when that happened. But it went. It wasn't like a 5-minute thing. It was 30 seconds at most. And then the next thing I know, you're sticking a little baby round Band-Aid on the back of my back. And you're like, get out of here.
I just got to show everyone that I did something.
Yeah. So, but I want to let everybody know it's not everybody's going to have an adverse reaction to it. Not everybody's going to have the worst case scenario. Don't believe the hype. Do your research on it. And even WebMD will tell you that not everybody will have the worst outcome on this type of stuff. Everybody's different. Everybody's going to react different. You may have a doctor that has a bad day and things can go wrong that way, right? So be prepared, be smart, be educated when you go into it. Do your cost-benefit analysis. For me, the pain was there. It was worth every chance I took. It was worth every penny we spent to get it done to see if I can get that. Because if I can get from where I'm at on my meds down, that's a major win for me. And everybody I've talked to knows that that's my goal, is to get my meds to the least amount that I have to take while still having a decent quality of life. So if I get 20% of this, dude, we'll sign me up again in a year, and we'll get it done again. So does anybody have any more questions before we release Dr. Leek out into the wild?
Yes.
And then release myself out into the wild, and we get ready for next week. Kevin, you got anything for me?
Victories?
Does anybody have some victories they want to share tonight? Whether you found your car keys, you got a shower, you got stabbed in your back, Anything at all, big or small, we need to celebrate them because we all definitely need to have victories. Shirley said, I watched my doctor perform surgery, made one numb from the waist down. Didn't know I could see it being done on the monitor.
Yeah, so I worked at places where they have a TV screen actually underneath your face. So there's a hole in the bed, and you look down and you can see what I see. Some patients want it.
Absolutely not.
Some patients, they'll put on like scenes of the beach and sailboats and things like that.
Ren and Stimpy or Pinky in the Brain or something. Anything, especially if I got the right anesthesiologist, Pinky in the Brain, I'd be fine. Right? I'd be more than fine with that.
I've not thought about that show in years. Thank you.
Dude, it's awesome.
You've unlocked a memory.
God, that's the best show, best cartoon ever, man. Yeah. Because who's the brain this week, really? Anyway, who's the brain, really? I think it's Pinky most of the time. Anyway.
Probably.
Barton agrees with me. Barton says, rather have no pain than take pain meds. I'd rather just not take pain meds. I hate taking pain meds. Kimberly says, still celebrating being home from the hospital. My victory for the next month. Hallelujah. That is awesome. Judy says, I'm always trying to see the screen so I can ask questions about what they're doing. See, I don't want to bother you when you're busy. I want you to...
Oh, thanks, Keith.
No, I was just... In my life, whether it's getting a car fixed or getting the house fixed or somebody sticking needles in me, I defer to the professionals. Do your thing. Mm-hmm. And I won't ask any questions,
Yeah.
I can't believe, Shirley, you've watched them perform surgery. I would have melted down. I would have melted down. They would have heard me 7 counties over screaming when that popped up that's just a nightmare. So anyway, next week we'll be back Thursday night, 7:00. It's going to be a good time. I want to say thank you to everybody for joining us tonight. Thank you for Dr. Leek for taking time tonight away from the family and the friends and everybody to hang out with your invisible community. Y'all keep Amy in your thoughts. Do that voodoo that you do for her. Love you guys. Until next time, we shall see you next week.